hospitals that are being financially challenged. And so they're looking at what they can do with the services that they're able to provide as well. My vantage point is that all hospitals are, again, interdependent upon each other. The larger hospitals need the support as well as the connections with the rural hospitals, and the rural hospitals need the support and connection of the larger hospitals. But I would say that, you know, the financial struggles that are happening is not just relegated to rural hospitals. That's all I talked about today, that they're facing some challenges as well from an urban perspective.
The nursing staffing, and you were talking about $60 to $80 an hour for these nurses that are being sent to you. Why don't we pay up and hire our own nurses rather than that?
Well, there's a couple different things to kind of think about. First and foremost, there's already a deficit in the number of nurses that we need for the state of Kansas. We're already probably 2,000, 2,500 nurses short of what we could use within our state, just within the hospital settings. Oftentimes what we've seen with some nurses is that they like the flexibility to be able to kind of pick and choose when they would be working or the locations that they would be working. And so we're seeing some nurses that have gravitated towards this nurse staffing agency model just to be able to have some different flexibilities.
Well, Jan, that'll be addressed more so in Connor's presentation.
Yeah.
So I'm going to ask my question a little different than Dawn. Are we closing a hospital?
No.
So why the purpose of this presentation?
Why
On
not?
your Medicaid expansion, all you're asking for is more taxpayer dollars. And for the taxpayers to pay more dollars to support your industry, they've got to be more efficient than what you people are being. You need to learn to be a little efficient in your industry, maybe.
And I think there's stuff that we can all learn from. And I would say from my vantage point, you know, we are being innovative and creative in terms of how we're delivering care. We're looking at different models of care as well.
Thank you for taking the time and preparing the presentation. I'm sure a lot of us, as we were going through it, a lot of the information was new to me because I'm not in the healthcare profession, but it's kind of doom and gloom when you look at what's happening facing, you know, the rural hospitals in our community. And you were talking about, and you listed seven small rural hospitals that have closed. My question would be, how many are opening? You know, I know that there are hospitals being built. Most people in this room that know me know that I'm not from Western Kansas, but I do know I have several family members that are in the healthcare field, and there are a lot of hospitals being built. Are there some being built, and are they doing things different that we could learn from?
Yeah.
Thank you.
Good question. The hospitals that we have seen a few hospitals that have opened, but those hospitals that have opened have been largely located in Johnson County in more of an urban setting. That's where population's starting to move, and so they're seeing, you know, the need for more accessible beds, healthcare services, and so we have seen that. I'm not as familiar of having, you know, rural hospitals having new, or communities having new hospitals within our state, especially the last number of years. From a hospital association perspective, we are looking at different models of care to try to be more efficient, as well as to be more creative and innovative, and quite candidly, have been working with Congressman Mann, Senator Marshall, Senator Moran on what we term as a rural emergency hospital, looking at different models that are out there. And so I do say that even though we are facing some financial challenges, you know, there's still a lot of optimism in terms of what can we do. It's still a passionate field. It's still a compassionate industry. It's an industry that's going to be, we need it to be there not only for, you know, all of our sakes, but as we have needs for healthcare services, as we grow older, we're going to need to rely on those healthcare services. And so in essence, looking for items that we can be more innovative and creative, whether it's using technology, whether it's using different models of care, or whatever the case may be.
Okay, with that said, thank you. I think we're going to move on to Connor, and maybe they have to switch mics around.
Okay. Thank you, and I'll be around afterwards if you have any questions, happy to answer any questions as well.
Okay, I'm hopeful you can all hear me okay. My name is Mark Estrelli. I'm the CEO of Gove County Medical Center. I have been with Gove County Medical Center since August 24th of 2021. I am hopeful today we can provide some answers to all of you. The why behind the closure, what we tried to do over a 6-month period to attempt to save the nursing home. We will get into some conversation about that. This is obviously a very somber conversation. I'm sorry that we're here today having the conversation. That being said, the interesting thing is Chad and I did not share our presentations with each other. I did not see his until Friday, actually Saturday this week in the afternoon. I had prepared mine earlier in the week, much earlier in the week, in fact, about Monday, Tuesday or so, after we announced the closure. A lot of the themes, if not all the themes that Chad Austin had presented today are things that are impacting us in our facility. They are reasons that we are in this. There is one major topic that we did not talk about that we will get into, which is the federal subsidies that we get to run our hospital, and how those subsidies do not make their way over into the long-term care setting. In fact, having a setting like the long-term care that is carved out of our cost reporting, which is the mechanism that we get reimbursed, it actually drives our reimbursement down, and so it impacts cash flow on every single charge, every single service that we provide. It drives that down throughout the year. And what ends up happening is we have a penalty that is between $1 million and $1.5 million. Is it cutting out? Okay, 1 second. How does this sound? Is that better? Okay, I'll try to continue to look to the left here as we talk. So, we will continue. I apologize for that. There are some topics we'll be talking about. You guys have met Chad. The very first thing we'll talk about is the story of our long-term care and maybe what the community has heard for years, and we will briefly touch on that. I did that a little bit with the cost reporting. We'll talk about the challenges that we had financially, the COVID healthcare financial implications that we are seeing. Again, Chad Austin had identified those for the industry. I'd like to show you with our audited numbers how that has been impacting us at Gove County Medical Center. We'll talk about what we did to explore the options with selling our long-term care facility and what that would have achieved and why that would have been sustainable, where Gove County Medical Center continuing to own and operate is something that penalty I discussed is only applied to critical access hospitals. We'll talk about the independent living apartments. We are hopeful that will stay in the community, so we'll talk more about that. We have done some things since I've been here in late 2021 to help stabilize some financials, drive some expenses down, bring some revenue in. But you will see throughout this that while we have done that and we have driven expenses down, expenses have increased so dramatically since 2017, in large part, even more so in 2020, since 2020 because of what I call COVID expense inflation. We'll talk about other things that we considered, and then we will walk you through briefly, and of course I hope there are more questions on this, because this is really why we're here today. What is going to happen with our residents? What are we doing to assist them in rehoming and transitioning. We will talk about our staff as well. We have a couple frequently asked questions at the very end that we will go over, and hopefully throughout that we will get a lot of your questions answered. And then we will fill the questions that we have identified. As David mentioned, everyone will have up to 5 minutes for question and answer in that time. If you have written your name down at the beginning coming in, that is to make sure that we respect the fact that there are a lot of questions, and we want to make sure that everybody gets the chance to ask their questions as much as possible. For years, in fact, when I got here at Gove County Medical Center, I was told about the 2016 Gove County Medical Center financial challenges that we had, and that by the end of that year, when you look at audited financials, there was $450,000 left in the bank. Did it cut out? There was $450,000 left in the bank at that point in time. There were some things that happened then, and we'll get into that, but when I asked, well, what did the organization do to bring us out of it? And there was very truthful answers to that. There was also very clearly a misunderstanding on the long-term care side. It had been said, well, our long-term care really saved us. When our hospital revenues are down, our long-term care revenues have helped drive some of that. Not only is that relatively incorrect on the income statement, because we have other departments that roll up into a long-term care, but there was no consideration for how the cost report is impacted. I will show you the loss per resident per day financially that our audited financials have been showing. I've reviewed them all back to 2015, all of our audited financials. Every single year it has shown a loss per resident per day on a significant dollar figure. The income statements in critical access hospitals are not what they appear to be, because you have all of this shifting of costs in the background because of the cost report implications. This is a problem that truly started in 2004. While you may not have seen the financial challenges until 2016, if it keeps going, I'll just grab the mic. In 2004, we became the critical access hospital. You guys may ask, well, if it's going to result in our organization closing our services, things like our nursing home, why are we a critical access hospital? Critical access hospitals, the federal subsidies, it is done in the way of reimbursing our costs. So if we are 60% Medicare on the hospital side, then 60% of our costs get reimbursed back to us. Once you start taking departments like the long-term care, this is not an actual number, so just as an example, if 40% of our costs are for our organization are in the long-term care, you now have only 60% of total costs in the hospital. So now instead of 60% of 100% of our expenses being reimbursed, you now only have 60% of 60% being reimbursed. That is a very large number. That is not actually where the expenses lie. I couldn't tell you off the top of my head what percentage goes to the hospital and what goes to long-term care, but I have some other numbers I can show you. So in 2016, people have said, well, why could we sustain it until then? Obviously we couldn't. 2016, we had to go to the county and ask for more tax appropriations. The administration and the board at that time did a very, very good job of cutting expenses in some areas. Things that I would have done, deferred maintenance, deferred purchases, things like that. Those catch up in due time, but that was the right decision at that point in time. So here are those numbers that I talked about, those audited financials. You can see in 2016, the final year before the financial turnaround in 17 and 18. In 2016, if you look down at the bottom, our audited financials show that we were losing almost $50 per resident per day. The income statement did not show that. This was right in our audited financials. 2017 came around, we increased the mill levy, we had custom expenses, very good job there. You did see that decrease, but look what happens over the years, and look what happens in 2020. And we'll talk a little bit about why that was not all COVID driven. It went up by the time it was 2020, it was back up at $170 per day. Why don't we just get the mic? Okay, hopefully this will be a lot better for you. I apologize for that. By the time it was 2021, our audited financials, the first year that I got a look at, we were losing nearly $200 per resident per day. We talked about this a little bit already, so I apologize I jumped ahead. $450,000 left in the bank at the end of 2016. 2017, increase in mill levy, increased tax appropriations as a whole, deferred maintenance and equipment purchases ultimately helped drive things down. 2018 and 2019, or 2018 was a year of stability and slight financial improvement. Here's what you guys need to know. Yes, in 2017 and 2018, our operating loss improved between, depending on the year, $1 million to $1.2 million. In 2018, so in 2017, the board, with the administration, voted in 3 years of wage adjustments and salary increases. Looking back at it, it was 1 increase per year per staff member, except for management, which got deferred largely until the final year. Those increases were, by the end of 2017, before those increases came up, salaries were $5.7 million. By the time those increases were finished and seeing the entire 3 years worth, at the end of 2020, salaries were $8.2 million. That's a $2.5 million increase. I want to be clear, that was necessary. They were losing staff. We use a wage scale across, it's the Kansas Hospital Association wage scale that has all of the data from the hospitals across the state, and all of the hospitals get that wage scale. They do it on percentiles. So that way there's a very clear indication of where you were paying your employees. They were below the 25th percentile. They had to increase. Whether or not they did it in a way that I would have done it, or whether I would have done it the exact same way, I cannot tell you. I don't know exactly what it looked like for them back then, but that is what happened. In 2019, which we would have seen a second year of increases at that time, you also had a benefits change. Those benefits that we provide to our employees went up $735,000 in 1 year. So I'll show you what happened pre-COVID. In 2016, they had an operating loss of $1.9 million. You see the improvement in 17 and 18, and you see us right back to where we were in 2019 compared to where we were in 2016. We were now losing another $1.9 million. We had more tax money. That was more sustainable. I believe the tax appropriations increased. Well, I can show you right here. It went up anywhere from $700,000 to $1.2 million, depending on the year. Some of that is the way that the county provides those fundings. They have to live up to their county budget, and so sometimes they have to make up for it the following year. So by the time in 2017, which we're comparing to 2017 because that is the year that we turned around financially, by the time 2019 came around, it had operating loss had gone back down another $1 million. Net patient revenue did increase $1.9 million, but total operating expenses increased almost $3 million, while the tax levy went up 474. So that's this number at the top. These expenses, what I wanted to show you was the primary categories that everything increased over those years. So remember, 2.965 million. These categories alone were 2,920,000 of those. Just these 1, 2, 3, 4, these 4 categories, or 5 categories right here, were pretty much every single penny of those increases. This is all before COVID. And by the way, 2020 still had another year of salary increases that had been approved in 2017. Supplies and pharmacy didn't go up a whole lot. Medical and surgical went up a little bit. To be expected, we are driving net patient revenues. Outpatient services were increased. It's the cost of doing business. The more services you provide, the more expenses you're going to have on the supply side. Salaries, however, went up 1.2 million. Benefits went up 772,000. And purchase services, which primarily consists of contract labor, went up 400,000. That would be about 2.5 of the 2.9 million in total, just those 3 categories right there, all labor driven. You see some of this continue to go throughout COVID, but then you also see supplies continue to increase as well. So the impact from COVID, you heard Chad mention what it has done to the industry. When I was digging through the numbers, I saw exactly what Chad had mentioned, which is our expenses have increased relatively permanently, while our revenues have increased temporarily. I'll show you that in one moment. Higher wages for employees due to wage scale increasing. I will tell you that although the board voted in 2017 to do a 3-year increase over 2018, 19, and 20, even if they had not done that, which likely would have been disastrous, we have to be competitive in our wages. Even if they had not done that, in 2021, that would have caught back up, because despite the $2.5 million in increases that they did, when I had gotten here, the board was looking at the wages again, and so I came into that situation, started working on it with them. We were already back down below the 25th percentile again in almost every single position. They were back to where they were in 16, where they were losing employees left and right, and wages had to go up again because we were having people drive to Russell for $400 shift pickup bonuses. We were losing our nurses. So we had to stabilize again, and if they would not have made that decision then, it would have caught back up in 2020 or 2021. They made the right decision. Contract labor at the height of COVID, you heard Chad mention, we had the same numbers in our heads, $60, $70 an hour for a nurse before COVID with contract labor, $200 at the height. It has since stabilized because of the exodus of healthcare workers. It has since stabilized at about 120 to 140. I used to be able to get 2 nurses for contract that I now need I used to get 2 nurses for the price of what I can now get 1. And I need more of them now than I needed then, or than Gove County needed then. One big piece, the allocation of governmental funds. If it was not for $8 million that this hospital got in 2020, 5.6 million of which they were able to keep. If it were not for that, and you can trend it out, and my CFO can speak to it, you can look. The hospital would have been, barring some miracle, the hospital would have been closed by the end of 2021 or sometime in 2022. Those injection of funds gave us enough cash on hand to continue operating. If we weren't having this conversation and making this very difficult decision that we are making today, you likely would have seen that actually catch back up to itself, and this hospital and this organization would have had about a year and a half left everything would have been gone, the nursing home and the hospital. I want to also address here, people have asked, well, what have you done with those funds? Well, one, you'll see the operating losses since 2020. We've lost it. We have also kept a lot of it. There has not been unnecessary expenditures. That is still in our bank. That is why we are still here today. If we had spent it or lost all of it, we wouldn't be. So here's since COVID. Remember, 2019, a $1.9 million loss. First year, 2020, a $3.2 million loss. COVID did not surge in this hospital until September or October, from what I talking to our providers, looking back at the numbers. We only saw a couple months of COVID, so we saw a little bit of revenue increase, but the majority of this, it's not on this slide, that last year of increases that I talked about, 2018, February of 18, February of 19, and January of 2020, in January of 2020, the salaries went up 1.2 million, 1.1 million. 1.9 plus 1.1 is 3 million. 3 million out of the $3,240,000. It did go down a bit in 21. Financials improved, but look at the revenue. Almost nearly $2 million increase in revenues. We have never operated this high. That was in 21. It was a full year of COVID. We had inpatient revenues, outpatient revenues. We were seeing people that were sicker than ever before. They needed more healthcare services. So a population that historically brought in about 3.5 million at the height. 3.9, some of that again driven up by COVID revenues, was now producing $2 million more a year. That, people haven't stayed that sick. Our revenues are dropping right back down to 2019, 2020 levels, which is to be expected. Sales tax actually went down $245, but again, we get roughly the same every year. That ends up getting allocated differently, depending on where the county is and catching things up. Total operating expenses, look how much it increased over that time. So $2,500,000 since 2019 had gone up. It actually only gone up $2.2 million for revenues. Call that $2 million after you reduce what you saw in 2019 for the tax revenues. Our ending cash, look what happens. 2019 we ended with $3 million, which, I mean, look, $3 million. What would have happened at the end of 2020? So when I say 2021, I don't know. I'm probably being conservative on that. Here's the money that we got from the county. Of course, a lot of that, from the federal government, a lot of that would have been expended that year, which is why you see when I say $8 million, you see about a $6 million increase, but we lost 3.2. You see that continuing to decline. Cash on hand in 2021 ended about, a little over $2 million better. Here's the major expenses. Look again, these are the categories. Drugs, I don't know what happened in 2019, but drugs actually went down. Supplies and other increased nearly $400,000. Supplies it stayed pretty steady. Salaries went up another $813,000. Benefits went up another $600,000. And professional services, again, a lot of which was contract labor, went up $710,000. Look at this jump. This is a full year of COVID. That went up about $800,000 right there. And that is that contract labor that Chad had spoken of earlier and that I had mentioned. Out of the $2,500,000 in increases between 2019 and 2021 in expenses, 2.3 million of that were these 5 categories again. The majority of it being salaries, benefits, and professional services. 2021, the increases, because I mentioned they were working on it when I got here, when we did voted in another year of increases. They would not have been seen in 2021 because I don't think they went into effect until November or December. That being said, our salaries look to finish, our auditors were on site last year, our salaries look to finish exactly, surprisingly, where 2019 did, where 2020 did, despite another year of increases. We are finishing around 8.3. That is probably because we have fewer staff than we did pre-pandemic. So that entire time, from 2017, the first full year of our financial turnaround, and our last year of audited financials, our operating loss worsened 1.4 million. Our net patient revenues, all these numbers drive into this. Our net patient revenues increased 4 million. Our operating expenses increased 5.5 million. Salaries were 2 million of that. Benefits were 1.3 million of that. Professional purchase services were 1.1. Those three categories alone were 4.5 of the $5.5 million in expenses. These are things that have to happen in terms of wages and competitive wages and not losing staff. You can't be paying a CNA $12 an hour when your competitors are paying $18. You won't have any of them. Then you won't have any patient care. I mentioned this based on the trajectory. It would close at the end of 21, sometime in 2022. That's probably being generous if we would not have gotten the COVID funding. What we have seen, and we had our auditors on site this last week. They come in about April of every year, March, April of every year for financials to audit the prior year. We have had to make a lot of adjustments to our books for expenses because every year when you get your audit, you have to go back and make those adjustments that the auditors are requesting. They were not entered correctly every single year. We have a major amount dating back to even 2019 that have now been adjusted and those expenses will be reflected on our 2022, whether it was a reduction or an increase. So I don't have those. What we do know is that we haven't made adjustments to our patient revenue. So the first half of 2022, we still had COVID numbers. We were still having sick patients in the hospital, extremely sick from COVID. Our highest month was nearly $1.4 million in net patient revenue. Our lowest month was 1.3. From the second half, so July 1 until February 2023, our last full month that we have currently, at least at the time of this presentation, was on average $1.2 million. That's a decrease in, well, here it's almost within $1,000 of a $200,000 monthly decrease in net patient revenue. The second half of the year and the first 2 months of this year, no COVID. That's why. If you annualize that out, we are looking at exactly pre-COVID numbers, between 13.5 and 14 million every year. 100% to be expected. Our highest month in the second half was about as much as our lowest month in the first 6 months of the year. The volume isn't there. We only have so many people in Gove County to take care of, only so many people in our geographic region, and they only get so sick. And when we don't have something like COVID going around, they're not sick as often and they're not as sick as they were then. They need fewer healthcare services. If that were to continue, and we drop back down, you'd see annual revenue of 14 million. At the height of COVID, our expenses had gone up 2.5 million. 18.3 million minus 14.2 million, we'd have a revenue shortfall of up to $4 million. Something has to give in order to continue to help these rural hospitals, including ours, continue to stay open. Again, the long-term care impact is $1 million to $1.5 million. We have had an analysis from our auditors that show exactly that. Again, expenses, we didn't put them on here. We're not hiding behind anything. We really, honestly do not know where those are going to end. But what you see is annually, this is monthly revenue. We break it down into the first two halves, or the first and second half of 2022, and then the first 2 months of 23. You can see our expenses are on the rise. They likely still will show that this year, once the financials are done. But look where our revenue goes from. After that first half of 22, our revenue goes back, and where is it? Right in line with 2020, 2019 numbers. So I took this to the board, this analysis in October. I was reviewing the audited financials that we received for 21. We got them a little bit later that year. We had scheduling conflicts. And so I was reviewing it in September, and I noticed that the back of our audited financials made it look like, based on the operating statement, that we were losing about $300,000. It didn't. I thought, okay, well, I've ran long-term cares for 5 years. It's completely to be expected. But when I looked at the front, it was showing me $190 loss per resident per day. If I remember correctly, I remember calling them and saying, why does the back say I lost $300,000? But when you times the resident days times the loss, I'm looking at a loss of $2.5 million. Something doesn't add up here. And my audit firm said it's somewhere in between. So full transparency, when you see $100 loss per day, 170, 190, it's not quite that high, but it is significant still. So we had our audit firm do an analysis off of our 2021 cost report. That analysis took it from a $300,000 to a $1.2 million loss. Truly, there was a $1.4 million loss in there too, but that would be based on, demolishing the nursing home space. It's a whole square footage thing. That's not what we're looking at, so we're going to go on the lower end of this. It was a $1.2 million loss. We did have them do the analysis on an interim cost report that was filed partway through the year, and it was actually showing that the long-term care was going to make a little bit of money based on just that one income statement. Even then, the analysis was $967,000, and on the high end it was $1.1 million. We took it to the board. I took it to the board in October. We had a conversation about needing to try to keep this in the community. Remember, if it's a $1.2 million loss, just for simplicity, a $1.2 million loss every year, then every month that we continue to explore this, we were losing $100,000. We explored this for 6 months. That's $600,000 that we kept on going with in the attempt to keep the nursing home in our community. One thing that you need to know about this, we were trying to sell the nursing home. That is because of someone else that is not a critical access hospital came in, and these federal subsidies would not have kicked in for them, and essentially the penalty that we get would not have kicked in. They wouldn't have that $1 million to $1.3 million loss every single year. It just goes away for them. Basically, it's a piece of paper that says, oh, your nursing home is a part of your critical access hospital. Great, give us $1 million. That's all that is. If it was not owned and operated by us, regardless of whether it was physically attached or not, that would not happen. We tried to sell the nursing home for $1, everything in it. We were going to sell all the equipment, our brand new call light system. We were going to sell the chairs and the beds and the tables for $1. That's all we wanted. We weren't trying to make a profit on it. We were trying to keep it in the community. We sent out to 10 organizations that had strong presence in Kansas. They were corporate entities. They ran a whole bunch of them across Kansas. In fact, one of these facilities, I can't remember the name off the top of my head, but they have been buying up nursing homes across the state for whatever reason. They were not interested. We got 4 responses back. Once they signed the non-disclosure agreements, and we sent them the financials, and we sent them our staffing, they came in and said, we're not interested. We have one say, okay, I'll come look. It was actually the one that bought up Logan Manor years ago. What they didn't tell us before they came on site was, we don't actually buy nursing homes anymore. All we do is run them for people. So you can pay us to manage your facility. And my thought was, and I confirmed this with our audit team, well, that doesn't help us. We still have the penalty. It's still Gove County Medical Center. And by the way, I'm losing more because I'm paying you more money now to run a nursing home that operationally and care-wise, we do just fine at doing. That's not the issue here. It's needing to get the million off of the $1.5 million off of our financials. So in December, they came on site. I did discover at that time that in order to sell it to another organization, we were going to have a problem. It was a problem of licensure. That license for the long-term care operates under the license for the hospital. It has never been licensed as its own nursing facility or skilled nursing facility, and that's really important to remember. So in order to sell it to another organization, I would have to get it licensed first, because they can't operate under my hospital license. It just can't be done. So in February, as we continued to go through this and we still had no buyers at the table, I was continuing to look to see what would it take to get this facility licensed. I tried very hard to get it licensed. There are physical environment requirements that are in place since 2011 that our facility, the structure, does not comply with, and those are KDAP requirements. If we had to comply with those, we would be better building a brand new facility, some other organization building a brand new one in our county and running it, and then gutting it and making it applicable to these requirements so that they can get it licensed. It's not feasible at all. It would be very, very expensive, and it would be very, very time consuming. Time is something that we don't have. Remember, the longer we have, every month it's a $100,000 loss on the long-term care, and we would only have about a year and a half in total. So time is not on our side. We sent out again to 4 more organizations, no interest. Lacey Hunter, the KDAX commissioner, came on site because I was telling her, I need to get this thing licensed. If you don't let me fall under the pre-2011 requirements, we are going to have no choice but to close the nursing home because I can't sell it. Meanwhile, no buyers, right? So she walked around with us, and what we found was, even after the waiver process, which would have taken months to do, we were fully prepared to go down that route if we had a buyer. Again, we did not. After all of that, we had firewall issues separating. We would have to create a firewall between the hospital and the nursing home. Again, willing to do it. We had no buyer. So when we sent out again, once more in, well, I can't remember, it was in February, I believe. So contacted 10 organizations again to sell. One came back. He came on site on March 6th. I thought that we actually had a chance at selling this. They seemed very interested. He was going to go meet with legislators with me in Topeka so that we could have conversations with them prior to putting it in front of the secretary who would approve this waiver. So we were going to go through all of this. At the end of March, he came back and said, we aren't interested. We sent the financials, we sent the staffing, they were not interested. Again, we're selling this thing for $1. I don't think that giving it for free would have made a difference. It's $1. nursing homes now, they are not profitable. They are impacted heavily by COVID. A lot of people, if they are buying nursing homes, are being very, very selective. I went to the board in March and said, we've exhausted our options. We don't have any other choice here. If we continue to do this, it is fiscally irresponsible. We have explored this for 6 months. We are losing $100,000 a month, and we have no buyers. We have this waiver process with the construction, trying to get a contractor out, which you all know how difficult that's going to be. That would take over a year. And again, we would have done it. But since this decision, we've talked a little bit. I've had conversations with people. Remember, we had a year and a half. This isn't going to fix Gove County Medical Center's financial situation. We have other things that have to take place. We will continue to lose some money, but you have to have money to lose in order to lose it. And if we took too long and we went down this route for a year, you can say goodbye to everything. So on April 3rd, we had a conversation. The commissioners were not aware of this. We met with them. We wanted to make them aware. We then had a special board meeting that had been posted, and we held that meeting, and it was voted at that time to to close the long-term care. It was voted unanimously because we had 6 months of all of these conversations. The board knew it was at jeopardy. We knew that this was not just a decision for the long-term care. We knew this was not just a decision for those that work and live in long-term care and the families that were tied to it. It was a decision for the healthcare in Gove County and the hospital, and it was a decision that ultimately, what would happen if we lost the hospital in Gove County? They would have amazingly detrimental impacts on the economy. More so than the impact that is, we acknowledge it. There is going to be an impact, right? There's going to be an impact from the closure of the nursing home. We all understand that. This would have been four times worse, arbitrarily. The independent living is a topic of conversation. We have that same financial impact, not dollar-wise, the same penalty that is applied to the nursing home, that penalty is applied to independent living as well. Fortunately, it is not a healthcare facility. It is essentially apartment complexes. Anyone can come in and run that. We have met with the commissioners. I know economic development is working on some things. We are hopeful that we are going to be able to get that space back to the county for them to lease it, so that another facility, or so that somebody can come in and operate that, and we won't lose the independent living too. That being said, the decision has been made, and it was voted on that day as well, that we will not continue to own and operate. That it is between 120 to 200,000, depending on the year and the losses that we lose in the independent living as well. And when you have other options in the community to run it, and we don't have to take that financial penalty that we get, it's probably the best thing to do. We can continue to run it that way for the county, not us. Here's that analysis. We had our audit firm come back in. These are those numbers that we were talking about, those losses. Here is if the independent living was tied to that. So if we ran it, if we closed it and it continued to remain idle, that's a net gain in 2021 of nearly 200,000, and in 2022 it's about 120. We actually bring in a little bit less if we give it back to the county, but that's not what that's about. We would just like to continue to keep the independent living in the county if possible. I mentioned we have done other things since I have been here. We have changed the benefits to the state plan. I had a year-over-year reduction of $400,000 to my expenses as a result. We changed the way that we carried our paid time off and the way that we pay it out when people leave. And that was in 2020 22, the adjustment was 204,000, so 600,000 between the two. That adjustment will vary from year to year, not the benefits, but the savings based on the vesting schedule. We're currently reviewing all of our prepaid expenses, all of our recurring expenses, and making sure we don't have any redundancies or anything that should have come off over the years. Revenue, we are working with integration with our partners at Bluestem, similar to how the government says, oh, your nursing home's part of the hospital, give us $1 million. They come in and say the same thing, except opposite when it's the clinic. They say, oh, you're affiliated with the hospital? Great, here's $1 million, right? It's the same deal. It's politics, it's how it works. Senior Life Solutions, I brought them in, projected annual revenue $75,000. We had a whole HPM, Holistic Pain Management. We were able to bring pain management services back to the community. They were projecting $250,000 to $300,000. Right now, it's going to be better than break even, but we aren't seeing what we had hoped to see. Although we are seeing, referrals to imaging and therapies and things like that will drive revenue. General surgeon, I've been talking to a general surgeon that used to come here. He is we're working on the contract right now to bring him back twice a month, once to twice a month, depending on his schedule. I've been in conversations with the dermatologist. Hopefully we can get dermatology here as well. Additional considerations on the closure of the long-term care. Staffing shortages, that was a secondary conversation, right, about why the sustainability of the long-term care is so challenging. Eventually, if things continued, and I'll show you some numbers here in a second, if things continue that way, it may eventually have become a primary reason. We have had, since 2019, and you can see our census declining, except we, on average, went up a little bit. Since 2019, look at our turnover percentages, 44%, 28%, 43%, 35%. We have hired far fewer employees, except for in 2020, than all the employees that we have lost. We don't have percentages here because it's annualized, but we have hired 2 and lost 7 in 23 alone. Tied to the rating, and I'm going to pause real quick. Our caregivers on that long-term care are completely amazing. They all do a great job. But when you need 4 hands and you only have 2, this is what happens. So when I'm talking about quality, it's not the quality that each individual caregiver provides. It's the quality as a whole that the organization is able to provide. And when you don't have staff, it's difficult to provide quality care as a whole. Our star rating, which is a measure of quality, has gone down every year that our numbers have gone down, our staffing numbers. Our reports to state have increased every year. Our reports of injuries have increased every year. And our healthcare associated infections have, on average, been far higher than they were in this first year, right on a per resident basis. People have asked, well, could you have increased private pay costs to offset that $1 million to $1.2 million? For simple math, and this is about right, we're around 12 or so private payers. If we had to offset $1.2 million losses with our private payers, their annual payments would go up $100,000. Almost 10 grand a month. They're already paying between 87 and 94. So on the low end, if they went up 70,000, and on the high end 100,000, they'd be paying anywhere between $157,000 to $194,000 per year. It wasn't going to offset it. There's no way. Nobody could afford to do that. I also want to mention, it might be later, but I'm going to jump ahead a little bit. The question has been, well, what other things could we have done to save the long-term care? Please remember, this long-term care penalty is year over year. Financial situations of healthcare organizations, including ours, we are not exempt from what the industry is seeing, have worsened year over year and have gotten even worse since COVID. Our revenues are pre-COVID, our expenses are at the height of COVID. That's not going to change. You saw those categories that we had. Those are labor, contract labor, and benefits drive the majority of that, 4.5 of the 5.5 million in expenses. And then, of course, you have inflation, supply chain challenges, things like that. Those are out of our control. We can't roll back the salary increases, and if we did, we'd lose every single caregiver that we had. So, what can be done permanently? People have said, well, can we get grants? As far as we are aware, and as far as what we looked into, we did not find any grants that cover operational losses. Well, what about the community? Could you find donors year in and year out to the tune of $1 million to $1.5 million? Maybe you found them for the first year, for the second year, you're delaying the inevitable. The only thing that is going to change this is the way that these critical access hospitals get reimbursed, the way that the federal government, hospitals decide that we are doing to take care of the sustainability of long-term cares in this country, whether or not they are attached to our critical access hospitals. They need to continue to thrive. They are shutting down across the country. Since I have left my previous state of employment, South Dakota, about a year and a half ago, 7 more nursing homes have closed up there as well. We are aware of at least one other nursing home that is actively closing here in our state on the west, I believe the western side of the state. What have we done for our residents? We have an approved closure plan that we sent to the state prior to sending the letters. We have sent out the letters to families, to all the state agencies that we have to. It's a 60-day closure notice. June 2nd will be the last day of operations. We have been meeting with families individually throughout last week to talk to them about their preferences, where they would like to be transitioned to. And we have, the team that has been assigned that has done a very good job. Within the first 3 days, they have found homes for 13 of our residents with, I believe, 5 or 6 more verbals from those facilities that they can take our residents. So if those ones go through, we'll have 19 of our 29 residents placed in a little over a week. We've kind of discussed this. We will give a 30-day notice once we find a location. We will work with the families to identify a date at that point once a nursing home accepts them. And we will work with that family and that facility, the accepting facility, to transition our residents. We will be packing their stuff. We have banker's boxes for all of our residents. We'll be packing it for them. We will be using our transportation vehicle for them. We will be doing everything that we can to make that as smooth as possible in an unfortunate situation. You can see the different meetings that we've had with residents. So 5 in total. All of them got an opportunity for their own. Employee notice, and if there are questions about this, I'm going to go kind of high level. We have some HR representatives in here that may be able to answer it more. We do have open jobs in our hospital, not enough to fill it for everybody that is being impacted by this, right? We'll transition as many as we can. We do have, our HR department has pulled 105 healthcare jobs just right in this area that hopefully they will use to work through and hopefully find opportunities for employment. We will assist them with resumes. We will assist them if they have questions about, how to interview. We will do a lot of that. Questions have come up. Well, how come I found out whether I'm a family member, a resident, a staff member? How come I found out from someone other than Gove County Medical Center? Were there maybe ways that we could have done it differently? After the fact, I'm sure there were. I'm sure that there are better ways to do it. We tried to put together a communication sequence that we were hopeful we'd be able to get to everybody before they heard through the grapevine. The grapevine moves very fast in small communities. You can only do so much about that. Were there opportunities to do things differently? Yes. In a couple scenarios, I am aware of a couple things that we could have done. But as a whole, we did try to do the best we can out of respect for the individuals that were being impacted. We've had numerous forums. We focused on our long-term care staff at first. We went in to make sure that we told all of our Gove County medical employees as a whole. We spent a whole day doing that. And we had a special department manager meeting to fill them in a little bit more than what they had been made aware of already. We are in an attempt to, one, help our staff transition through this time, make sure that they have pay, things of that nature, but also make sure that our residents have staff members to care for them. We have offered severances. We are hoping that that will help with retain them through that period of time. They're eligible for their PTO payout following departure from the organization. And then our HR department has worked with them on all the termination stuff, the different services that we have available, all the paperwork they're going to be made aware of. One big question is, what if Gove County Medical Center caught this penalty sooner? What if they caught it before 2016? What if they caught it after 2016? What if they caught it before 2021, when it was possible that the hospital would have closed again if it had not been for federal funding? Could something have saved the nursing home? I don't know. Maybe is my answer. The reason for that is because before COVID, more organizations were willing to buy nursing homes than they are now. They would have had to go through everything that I researched the last 6 months, the waiver, the construction. I brought in architects. I met with fire marshal. I met with the state. I met with, anyone that would be willing to come buy the nursing home. They would have had to go through that process. Would they have had enough time? Would they have had more money at the time to do that? Could they have found a buyer? The answer is maybe. I can't go back in time and tell you what would have happened. What I can tell you is COVID would have still happened. Expenses still would have increased. Salary and wages still would have had to go up. Contract labor still would have gone up. And the nursing home would have still had $1 million to $1.5 million hit every single year. The things that drove this decision still would have happened. The big maybe in all of that, because remember, we're at the max on our mills. There's no more county money coming in through that mill levy. The things that drove that would have still taken place, and the hospital still would have had a decision to make for the longevity. If anything, not identifying it sooner maybe got a couple more years out of the nursing home. But a decision would have had to happen. Hopefully they would have been able to sell it, but what ifs can't be part of the conversation, right? What if we didn't make the decision to close the long-term care? We would have lost both the long-term care and the hospital in 1.5 years. The largest employer would have disappeared out of Gove County. It would have had a detrimental impact on health, wellness, and mortality. Families, more so than what is going to happen as a result of this, would have to leave, possibly leave the county, taking their kids out of our public schools. And there's a strong likelihood that the economy, as a result of all that, in Gove County could have collapsed. I don't know how long, I don't know for sure if it would have happened, but given the economic impact of our hospital, of our schools, I think there's a strong likelihood. So I hope you all know that we didn't, after hearing all that, we didn't wake up one day and say, we don't want to run a nursing home anymore. That did not happen. That never would have happened. I ran them for 6 years. I love our nursing homes. I love our nursing home. at the end of the day, if we have to have, and we could have lost both facilities in a year and a half, a decision had to have been made. And if I have to stand up in front of all of you and be the one to bear that news and be instrumental in that decision, then I'll do it. But this county deserves to have their health care moving forward. They deserve the jobs, and they deserve, in general, just a board that is going to be willing to make the difficult decisions. I don't like that we're here. I don't like that it is having an impact on our families and friends and staff and residents. But as you can see through the financial process and the impact, the economic factors and that economic impact that is out of our hands, and by the way that we get reimbursed, which is out of our hands, you can see that there wasn't a lot of choice for us. We explored the choices that we had available to us, and it turns out they weren't as available as we hoped they were. So thank you for taking this time to come out here, have this conversation. I will pass it on to Dave. He will go over the question process again, and we will then start fielding the questions based on what we had received them coming in. So we will get to you. Please know that. But we do have a process for this.
Okay, we'd like for you to come up here if you could, so we can everyone can hear the questions. First one I have on the list is Linda McIntyre. No question. Okay. Jack Sawyer.
No question.
Jan Frederickson.
I missed something in this whole process of all these numbers of the formats. The nursing care center is going to lose 1.2 million. The total facility is losing 4 million. How do we recover the other 3.5?
Okay, sorry. So yes, the shortfall is still there. That is what I had mentioned earlier on, is that this can't be the only domino, right? It's unfortunately a piece of this and what we get penalized for. That shortfall of $4 million, that was based on the COVID height of expenses, right? And I believe it was 2021. Hopefully we'll see some of that decline in 22 because we won't have, the supply chain issues and whatnot. But as far as the remainder of that $600,000 I talked about in benefits, that wasn't in the 2021 financials. So there's another $600,000 on top of that. Our partnership with Lucent that we are working on, that will be another $500,000 conservatively, because we were really conservative with that pro forma. So when you start looking at just those three things alone, you start looking at closer to $2.3 million. You still have a $1.7 million shortfall if it was if the loss was as aggressive as what I had shown there. I was just showing the numbers. We don't know for sure that that's what it's going to look like. But we do know it's not going to be good. So even if that came in $500,000 less in terms of the shortfall, well, you're now looking at a very manageable thing moving forward. We're still working on various things, but rural healthcare is becoming very difficult. I can tell you that those things in themselves would have moved at about 2.4 million, probably a little bit more. So we're doing our best, and we will continue to find revenue opportunities and expense saving opportunities. I can't tell you that that's going to fix everything. There's still more work to be done.
Next is Roseanne Smallsbury.
Excuse me. Obviously, looking at what you've done here, none of us that are sitting here can argue with that. But my question is, okay, there's always a way. There's always a way. It's such a thing to impact all of us. You can see my gray hair. You know, we have to have this. So how can we have it? Could a co-op be formed? I mean, everybody that's here, this is going to impact financially one way or another. So instead of it impacting me financially the way that it's going to, is there a way that I could be proactive, helping to organize something that will take care of us in the future? Have you considered anything like that?
Yeah, so very good question. I will answer that in a couple of different ways. The first is that we have, yes, somebody could come in, right, and they could build a nursing home and they wouldn't have that penalty. Because of when they do that, they will come in with a brand new nursing facility license, which means it would fall under the post-2011 physical environment requirements. The space that it currently resides in would not be an option because it's a brand new license, just like it would have been if I got the independent nursing facility license. They would have considered it a new nursing facility, one that had never existed before. So while that space is not available or doable, feasible really, another nursing home and a company may be willing to come in town and build that. They wouldn't have that financial impact on that penalty. That being said, I also showed you the staffing. We only have, well, you heard Chad at the beginning, a shortfall of nurses in the state, 2,000 to 2,500 nurses that are not in the field that we need. Right? That's not getting better today. They've got to be able to staff it. And quite frankly, we have challenges staffing it now. So it would have to come in, it would probably have to be a little bit smaller. It would have to be built in a way that took into account workflows and things like that so they could optimize staffing. It's possible. It just, if Gove County Medical Center had anything to do with it, it would be owned and operated, right? And then we would have that $1 million to $1.5 million penalty. I don't know if that answers your question.
The other part of that, the answer to that is, if we can get some federal laws changed, that's where Sarah comes in. And we need to get the licensing thing in the state of Kansas, which I've been contacted with some people. People have contacted me. We're trying, he has contacted either some legislators or people that know legislators, and hopefully we can go down and impact them to hopefully get this law changed somewhat. Because he gave me an example of it, and I don't know if it was a new facility or a rebuilt facility. This facility was not given a license because the hallway was 1 inch too narrow. So this has got absurd. Anyway, thank you. We think this next one is Patricia Stone, is that correct? Okay, thank you. Mail and title.
I don't know where to start. Honestly, I've sat there as a commissioner for 20 years, listened to hospital audits, and you made about as much sense as they did. You just kind of blew smoke. You did a whole hospital audit. This is just long-term care, right? Now, who gets this penalty you keep talking about? You sent them a check for $1.5 million? Or is it reimbursements that you get shorted?
Reimbursements that the organization gets shorted because it does not take into account all the costs that we actually truly have as an organization.
When did you decide that this was all in trouble, about 2016?
You can look back and that penalty has been assessed every single year. You'd have to go back and ask the audit firm to analyze it so they can actually show what had happened, because again, it doesn't show up in the income statements, but it does show up in our cost report, which is a far more complex thing. So the impact in 2016, the fact that you were, that Gove County Medical Center was, at the brink of closure, that penalty's existed since 2004, so that certainly had a big piece of it. You can't lose $1.5 million every year for 12 years and not say that that had a piece of it.
But I'm a little bit like Dave, why did we sit here and not be aware of this and not petition our federal officials or state officials to do something different? And is this law or is this regulation?
This is reimbursement mechanisms, which are regulations essentially, right? It's how CMS.
So if you go to the law makers, they're going to say, well, we don't have to do with that, but the bureaucrats are running that. Yeah, right?
I'm probably not the best person to answer. All I can say is that at this point we can advocate and hope that this doesn't impact future organizations. Hopefully a change will be made. As far as the question of why was this not caught previously, I've only been here since basically September of 2021, right? I caught it in the first audited financials that I received back. I can't tell you. Cost reporting is very complicated. I can't tell you what they did see, what they didn't see, and what conversations had been had prior to my arrival here. What I will tell you is that, as complicated as it is possible that it wasn't fully understood. And I think at the time it was hopeful that, we survived with the nursing home for 12 years, right? The nursing home couldn't possibly be part of the problem. I can't tell you, I cannot speak for anyone that was involved in that beforehand. All I can tell you is that we have, since I have arrived, identified it, and we have confirmed it through an analysis with our audit firm, and it is correct because they do our cost report. So I apologize that I can't answer from before that.
So, how many times, Dave, have you met with this people from Topeka?
We haven't yet. I just received the call.
I thought you were trying to get this correct.
Yes, we are, but I only.
How many times has the board met in the last 6 months to solve this problem?
Probably, yeah.
Really, it looks to me like y'all be meeting pretty every day.
No, that's what you're.
And you didn't tell the commissioners until April the 3rd? Is that what I heard you say?
Yes.
Well, we thought we had sold up till.
Well, but how were you going to do this? Now, when I was commissioner, that belonged to the county.
Yes.
We can sell I ran this through our attorney. We can sell the business within the facility. We cannot sell the building itself or do construction without that. So any construction that we would have had to do, we would have had to go to the commissioners. Yes, you are correct.
Your attorneys would be one attorney's opinion, and you can call another one and get a different opinion, I'm sure.
I did.
You could get different opinions, I know you can. I mean, whether the business belongs to Gove County or to the hospital, that would be questionable, I guess. I don't know. I don't know how you can sell it. You have to jump through certain hoops to get rid of the county property, And then, how many employees do you have?
175.
And how many are going to be affected by this long-term care?
34.
Seems to me like the most efficient part of your operation is long-term care.
It shows through this, it's not.
Well, but then I know how those audits work, and Don can talk to that a lot better than I can. I just don't believe your figures, and I don't always believe the figures that they gave us on hospital audits. But when I was commissioner, they still told us we had one of the strongest hospitals in northwest Kansas. And 9 years, it's gone broke.
The audits, I mentioned that the numbers in the back were incorrect and that the numbers in the front showing the 190 days loss, you're correct. Those were not 100% accurate. That's why we had to get with them. Now you may say, well, why is it inaccurate? Because they were taking the cost per resident day for the entire cost of the organization in terms of how the costs get allocated. So yeah, we didn't look at those audited financials and take them at face value either. That is why we did due diligence to get with our audit firm to do the analysis on the true impact of that. We are confident that they are doing that audit the way that it should be done, but cost reporting is very difficult and behind the scenes.
The way I understood it, and it's lots better if we could have these figures in front of us too. You had a bottom line up there that showed that your long-term care was gonna make 900,000, and then in another year it's gonna make over 1.2 million or something like that.
That is the loss that we experienced from the cost report implications.
It wasn't shown as a loss.
At the very least, I discussed it as a loss, so I apologize if it was incorrect on the slides. It will be a net gain to the organization after the closure of the long-term care.
Okay, 5 minutes is up, we'll go on to the next one. Pete Foster.
So I have a couple of questions. I just want to make sure I understood this right. So you said that the independent apartments were losing money, 1 million?
No, 150, 200,000.
Okay. So I guess I don't understand how that happens because I know they don't receive nursing care. It's all private pay. I know they get a little bit, they get cleaning, and I know there's overhead costs that are allocated to that department. But I guess I was surprised that there was that much loss when it's all private pay. Can you explain that?
You and me both. Actually, I was really surprised by it too. In fact, Viola, our CFO, and I, she ended up being correct once we reached out to the audit firm. I was arguing with her that no, there's not. Well, the way it works is costs are spread out over a square footage. That's a piece of this. I'm going to do as good of a job as I can explain this. It's spread out over the square footage, and then because of the rules and cost reporting, all of our overhead expenses in the organization still have to get allocated a certain bit based on that square footage. And so independent living, just like the nursing home, gets carved out. It is non-reimbursable. So on any expenses, because I said the same thing, you've got 10 residents over there, or 10 tenants over there, you're going to net over 100,000 because the expenses are so little. Well, that what I showed, the $120,000 to $200,000 loss, was only after the revenues were offset. So the revenues were built right into that.
Good afternoon, I'm Viola. I just want to clarify, independent living on its own, not associated with the hospital, makes money. I don't want to discourage anybody who might want to run it. If it's just your business and you're running it with the rates that we charge, you will make money. Having it associated with the hospital has the same rule as long-term care. We get penalized. When we're talking 150 to 200,000, that's the penalty that CMS charges us and won't reimburse the cost. But if you're interested in running a profitable business, thumbs up. It makes money. Okay? I just wanted to clarify.
Thank you.
Okay, my second question is, so I wanted to clarify this. If the facility purchases the Houston Medical, we would get $1 million because they are associated with our facility?
Yeah, so what happens is you become what's known as a provider-based clinic. In other words, a department of the hospital. Because of that, it's a piece of paper that says, oh, you're no longer a standalone clinic, you're under a hospital, okay, we'll increase your Medicaid and Medicare rates. And so they end up paying more on top of that. We get 340B, which is through, the drugs. That's very complicated, I can't explain that. But there's revenue there that the organization would get that the clinic can't get without us, and we can't get without them. So yes, a piece of paper that says, oh, you're operating the same way you've always operated, great, well now you're under the hospital, wonderful. Now you can be provider-based, which brings in more revenue, and you can be eligible for 340B, which brings in a significant amount of revenue, And it is all because of a piece of paper. Yes, we have to stand some things up, we have to do things with 340B, we have to fill out an application for provider base. I've already had architects on site, that's not going to be an issue. No money needs to be invested into the infrastructure of the facility. It's just going in, checking off some things, sending it to the state, and we're approved for provider base. 340B is a little more complicated.
So purchasing the Houston Medical is gonna be a profitable thing.
100%.
Okay, thank you.
Yes, thank you.
Terry Evans?
So I actually talked to the public. What happens to the current long-term care building? What do you do with it?
So, obviously over the last week, our focus has been on staff, residents, families. We will be assessing that space. It is not going to get boarded up. We are going to continue to maintain the space. We have, on our end of the independent living, goes through, we would take the two businesses that we run out of there, respiratory therapy and Senior Life Solutions, and we would have to make space for that over in the nursing home setting. There's no space whatsoever for it on the hospital side. That is why it's an independent today. And then we will have to be assessing all the remainder of the space. You know, we've had conversations organizationally about, you know, what do the future of services look like? And there's going to have to be space for that down the road. I want to be really clear though, because I know what's already being thought about by everybody. Well, so you're doing it to make room for other services. No, we haven't even talked about what's going over there other than if the independent living closes, we will have to take or not closes, sorry, if someone else leases that space and runs that business, we will have to take our business out of there and put it over there. So we don't know yet. It will be maintained. It will be well kept. It will not be boarded up.
Won't there be a significant cost to remodel that then? And what does that do to the hospital bottom line?
So again, let's differentiate between annual recurring losses, like the long-term care, and one-time expenditures. One-time expenditures and capital purchases and construction, you know, they're going to happen for services. As far as those two services, no, I would not anticipate very much money, if anything at all, really having to go in for renovation. It's sleep studies and it's Senior Life Solutions, which is group therapy. You prop up the tables and the desk and all that stuff that we already have and just move it.
What did the real estate you guys have purchased in the last, couple years, how did that affect all of this?
So, I wasn't here during, because I sought out that answer too. I wasn't here during all those purchases. I do know that the last one, because it kind of got closed like right when I got here, finished. That was done through a gift through the Porter Trust. So it was, I believe, donated through one of the local foundations, and then a portion of that was taken to purchase that home. It was, if I remember right, like $15,000. It was not in a it didn't even take up all of what was donated through the Porter Trust. So.
Okay, next question. This should be my last one. Everybody's got their own opinions on what's going on. There's a lot of really upset people because we do have an older community. Why was there not like a meeting beforehand to tell everybody, hey, you know, does anybody have a solution?
Well, and as he stated, we were trying to the last second, because we problem being with that, if you let that get out, and we do get it sold, we're gonna lose employees, and then we're not be able to staff it anyway. So it's a double-edged sword kind of thing. You could go either way with that. Connor, will you add?
Yeah, so if it would have been communicated in advance, and I've asked people this, if you thought that your job was in jeopardy, would you have left and not given things an opportunity to maybe work itself out? And I think a lot of people would say yes. Some people may say no. But I think it would be a mixed bag, and you saw our staffing challenges in long-term care already, right? What if we had found a buyer, and by the time we found a buyer, we no longer had hardly any staff over there to staff it? They would be relying on the workforce in Gove County to bring that. Now, could they have hired people that had left? Sure. All we can do is control what's in front of us. I can't tell you what's going to happen down the road. Could they have hired the people that left? I don't know. Not if they were really satisfied in their new jobs. If we started pushing that out there, it would have been extremely challenging to even start having the conversations, continue the conversations about someone acquiring that practice, the long-term care facility. So that's going to satisfy some people, it's not going to satisfy others. Could it have gone the other direction? Sure. Do I think that the negative side effects of that would have been very large? I personally feel that way, yes.
I don't know, it seems to me like the people that are still working for Gove County Medical Center and stuff is out probably still would, because they're probably local.
Thank you, Terry. Deb Schoenberger?
I have
Okay. Keith Funk?
no questions.
Thank you. Dick Sterrick?
I'll pass.
Okay. Don Tilton?
First off, we were aware of the so-called pendulum, we didn't call it that back in 2016 or 17. Obviously, by the statistic that you showed, it's widened, it's more of a significant issue. Secondly, back when we were in trouble in 2016 or 17, the board at that time went to the public. We were very transparent. We threw numbers at them. We had brochures, we had everything. We didn't have Facebook much back then. And we laid it out there, and we were told many times, did anybody like to have the 16.5 mils? Nobody was in favor of that. Kind of like I don't pay more income tax than I'm required to do. Nobody ever does that. But the recurring message was keep the long-term care open. Not at all costs, I wouldn't say, but the insinuation was keep it open. Okay? So we were aware of that. Was it 1.5 million? Probably not. It was probably a factor of that. Okay? The second piece of that I read through the minutes from October through February. You wouldn't release the March minutes because they're not approved. I read those. I read the open session, and I don't see any indication that this is on the table. I see a lot of executive sessions that now you can find a piece together and you make the comment. You have 19 of them or 20 of them that I've read, and you keep referring to confidential data related to financial affairs as being your reason to go into that executive session. Can you explain what you think that means?
I'll try it on.
Okay?
Number one, I don't remember anything back when I was on the board after that about the long-term care making money, or losing money, excuse me. Now, I could be mistaken. That's on that one. Well, we got to the attorney again. All Gove County Medical Center financials are part of open meetings and have been provided to anyone asking through Cora. But the statute you referred to is correct for the basis for executive session to drill down on financials. The statute is 73-4919. 4319. Number one on that is discuss personnel matters and non-elected personnel. To discuss data relating to financial affairs and for primary discussion of acquisition of real property. That falls under that.
You're correct. You mentioned several of those justifications in that relation. I haven't the statutes right in front of me, but one that talks about, what did you say again, the wording? Confidential data related to financial affairs is to protect a private party talking to you, i.e., if you have one of those companies wants to buy it, and they want to submit their financials to you, they have trade secrets, something they want protected, you're allowed to go to executive session to talk about that. Hey, Don Tilton Incorporated, you want to buy it? I'm going to give you my financials, my W-2s, my tax returns, whatever. I don't want that in public session because I'm a private person. And that way I read it, that allows you to go to that executive session and talk about Don Tilton Incorporated. That's it. You can't continue to talk about GCMC
overall financial developments, good, bad, ugly, in executive session. Am I missing something, Matt?
So, could we have done a more thorough job of identifying what exactly we went into executive for? Sure, in some scenarios, we were talking about exactly what you discussed. We were also talking non-elected personnel as well, right? This impacts the employment of everyone on that side. Additionally, as it relates to the acquisition, we were looking to, yes, get rid of that, but it was an acquisition that we were talking about in terms of the acquisition of a business, someone coming in and acquiring that in relationship to Gove County Medical Center. We are confident in our conversations with our attorney that all these discussions that we had in executive were appropriate. Could we have done a better job of identifying specifically? I'm sure we could have. Just as you had mentioned in our conversation that you could have done the same on the board years ago.
That's correct. Yeah, you can read the code, what we call the Kansas Open Meetings Act, which applies to you and the county commissioner, school board, etc. I don't share your enthusiasm. There again, if you're talking about the overall structure of the employees, you can go in and talk about Jan if he's an employee and how his actions affected the hospital with long-term care, but you can't talk about salaries as a whole. That's not considered part of the justification of executive session. And back to the confidential, it says very clearly to protect the financial information of a private entity, which is me, Don Tilton Incorporated. It doesn't allow you to continue that with no mention about why you're going in. It also requires you to say the subject, why we're going to talk about long-term care finances. Here's the justification for being in executive session. I don't see that anywhere where it talks about long-term care finances, GCMC finances. It gives the reader no indication what's going on. I'll keep talking and let you talk. I know I'm not asking the question, but I talk too much. I akin this a little bit to a school closing. And school closings are terrible. They're emotional. People have been around. We've had it in our community the last 20 years. But you don't do that with 5 people or 7 people. You're transparent. You talk, great presentation today, just 2 months too late, 2 weeks too late, 6 months too late.
John,
A lot of information there. That's not a question, I understand. I firmly believe, and my county attorney agrees with my assessment on the confidential, that you have violated the Kansas Open Meetings Act several times. There again, like Mayor said, you get a different attorney, you get a different opinion.
Next question.
I think you violated the statute many times. Well, 19 times plus 2, 21 times I can read.
I don't know about
That's your
that figure, but what I
read
will,
the minutes. I can count.
what I will tell you is that regardless of what happened in those scenarios, unfortunately, whether conversations were public or they were not, because I mentioned to you that, people come and said, well, what about the community? Couldn't the community have help? Couldn't they have done X, Y, and Z? Sure, there might have been something out there on
If
it.
we would have known about it, it'd been good.
One time.
Some ideas out here that might have
All
helped
right,
us.
guys, that's enough. 5 minutes is up.
Okay?
Kathy King?
Can I have 5 minutes, Keith? I have Keith's 5 minutes.
No?
You still haven't answered my question.
No, we got your name down. You had your 5 minutes. Thank you.
Okay? I don't let the county attorney figure this out, or the attorney general, whether you violate the statute.
You got every right to
Because
do that.
that's what we're on.
Done. You're
It's
done.
our county hospital.
It is.
It's ours.
Sit down, Don, we love you.
Whether or not we all agree with that, we're going on to my next question. And apparently, my first question has been answered, because how many questions can I ask? I'm limited to 5 minutes, right?
Yeah.
Okay. Somebody asked me that they put their name on there, and I almost hate to ask this one first, because I'm afraid it's going to take my 5 minutes. Why are we a critical care facility in the first place? Don't take too long.
Okay, I will make this very short for you then, and I kind of addressed it a little bit at the beginning. In '98, when this designation came out, rural hospitals across the country were closing. The government stepped up, said we need to do something to save these hospitals, and this reimbursement mechanism was what was needed. Now, fast forward 6 years, 2004, the hospital became a critical access hospital. I I don't know why it waited 6 years. I don't know if it was fine back then. I don't know what economic factors and forces changed in that period of time to make them want to be a critical access hospital. All I know is that without that, we would be in a far more dire situation. We would still have all these expenses of operations, right? But we wouldn't be getting reimbursed any of them. So if 50% of our costs are reimbursed on the hospital side, you now have 0%. Imagine what that does. We'd be closed tomorrow.
Okay, I have to make a statement before I can ask the next question, because a lot of people are going, what the heck are you doing here for? Because if you aren't involved with the hospital or the long-term care, you might not know that my mother is 99 years old and in that facility, okay? We don't have a placement yet, mostly because the people that are being taken are mostly those that are able to walk and talk and take care of themselves to a big degree. She's not. Some days she's better than others, some days she's not. Right now, today is a good day, but I haven't gotten to see her because I had to come here. What happens June 2nd? I don't have a place for her.
So before we started looking into all the bed availability within the 60-mile radius, I shared the same concern, 58, but I was very concerned that we wouldn't even have that, right? I am now, especially with the placements that we've had, I am more optimistic. There are still beds around us. I believe that a lot of these facilities will, receive the call to action pretty well, that we still need placement for our loved ones. As far as what happens on June 2nd, that is a question that I don't have a specific answer to, because what happens with the state discharge plan or the state closure plan that has been approved is it allows for emergency discharges if you do not have the staffing. If we continue to have staffing, which is the big wild card in all of this, past June 2nd, then we will have to continue to operate. But one's going to fall before the other, right? Either we're not going to have staffing or we are going to discharge our residents to new locations. We will have to work with the state and begin conversations starting this week and in anticipation for that, if that happens, because leave it to the regulations to not really expand upon it. We don't know what emergency discharge looks like.
Yeah.
We've got to figure that out.
The other issue is a lot of these places, I learned a new word this week, acuity, which means how well are you able to take care of yourself and how well are we able to take care of you based on your need. And mom falls pretty far down in that. The thing is, almost every place I've talked to that said, sorry, we can't take your mom, has said, but we could take some of your employees. However, if the employees stay till June 2nd to get their severance package and their unemployment and all of their benefits that they're entitled to, those places aren't going to be able to take my mom before June 2nd. Because the employees have to stay in winter.
So,
it's a double-edged sword, no matter which way you look at it.
yes, well said, it is a double-edged sword. If we place half of our residents in the next couple weeks, right, we will be able to work with those staff members that have jobs lined up, and we will be able to then give them their severance and let them go early if they have jobs lined up. So it's kind of a phasing process.
So they're not going to lose
them
their severance if they leave before June 2nd, under those circumstances?
Under those circumstances, yes.
Okay.
Yeah.
And you know already, I'm very emotional about this because I love my mom.
You should.
And as I said Saturday, in the room with the residents, the employees that were there, and their family members that were there, most of the people in that room, other than hospital staff, didn't have a clue who I was because they came from everywhere to come see their loved ones. But all those residents know me because when I go visit my mom, if she's asleep or I don't leave, I just go see somebody else. And I bring the dog, and I brought the dog one time 3 times during the day before mom was awake. But
You know how many residents got to see that dog and play with it? I have no clue. I know those residents and they know me.
Okay,
And how much more you know.
thank you, Kathy. Deanna, Zara? Dina, sorry.
Most of my questions were also answered, so we appreciate the time frame. You shared that there's 174 employees currently and 34 long-term care. Obviously, I mean, thank God, I mean, look at the turnout. When you sit up and you turn around, what caring, loving, we're so, so blessed with a loving and caring community. Loving and caring doctors and staff at Gove County Medical Center. What other departments are truly going to be affected? How many employees? I mean, I'm not as familiar with Gove County Medical. There again, that's not my background in my professional area. But I know there's basically 12 rooms. And I mean, are those rooms 50% full at the hospital? I mean, I would imagine there's a lot of employees that go and work with that
I'll
long-term
let
care
Connor
facility.
address
So-
that.
Good question. Leading up to this, we were having those conversations, leading up to the announcement. The challenging part is that there will be some departments that will be impacted by that. We are working with those managers to see what that does to their staffing plan. I can't tell you how many, because until those managers come back and say, you know, this is how much time was dedicated over to the long-term care setting, and this is what it does to my staffing. I can't tell you that answer, but we are going to be working with them, especially now with this week, very close, but we have already had those conversations with those. There are about 3 departments that could see some impact from that.
And, you know, I know it's easy for us, you know, our emotions are all running high, and everybody in here obviously cares about what's going on. But as Dawn shared, you know, you have a wealth of knowledge in this room. I know you're not from the community, but let me tell you, I'm not either. I've only been here about 14 years. But we have some very bright, knowledgeable people here. Tap into those people. Have some more public information meetings. You know, I have a professional background as well with administration and serving on boards. You need the knowledge base of your community. You need their input. That would help. Having that awareness early, even as a manager at the hospital, the departments that are going to be affected by this, that gives them time to research. One other question, oh no, you had talked about what would happen to the facility space. So since that question was answered, let us be aware of that. Let the community, because there is going to be a cost there. As a former manager of departments and school administration, there's going to be a huge cost. I don't think it's going to be minimal, but what's going to happen with that space, and it will be a reoccurring expense, and all business is reoccurring expense. But I appreciate you guys all being here and having this meeting, and just, please keep the public more aware.
Thank you. Nadine Hargett?
I'll just be real brief. Kathy answered my question. I mean, asked my question because I'm concerned about the LTC residents that didn't have homes. That's what I was concerned. I was like, what are we going to do if you have to?
Thank you, Nadine. Colleen Thomas?
I know it's been said already, but I myself as a planner and the former CEO, when we went to do the revenue mill levies, we had public information meetings prior to it. And I think part of the problem with this whole situation is the letdown of you not letting the public know as a board, the county commissioners and you, Connor. I see the figures. And they are very, very humbling. They are depressing. And it's been going on for a while, and
You know, we were aware of those things, but they weren't quite the loss. And I think COVID had a lot to do with your big losses. So just keep that in mind moving forward, that that never happens again, especially like with our hospital. Another question, the public transportation ban, what's gonna happen with that?
Yeah, so because this is a common comment, I am going to address the comment that you made. So I don't think anyone is up here saying that in no way could we or should we have done it the other way. Should we have brought people into the conversation in advance? I think both of those situations, the way we did it and the way that you recommended that we do it, I think both of them have their upsides and downsides. I don't think that there is no good way to close a long-term care facility. There is no good way to communicate either in advance or after the fact. There are going to be challenges no matter what. It is, when you weigh the risk and benefit, what we did, the risk and benefit of that is the staffing challenges that we were going to have. So was it the right way to do it? I don't know. I can't tell you what would have happened if we would have done it the other way, but we did have our concerns about it. The second question, I'm sorry. Transportation ban. We, as we get through with these conversations and continue to look for transitions of our residents, we're going to be utilizing that heavily. We are also going to be reaching out and have been reaching out. I just haven't circled around with anyone yet. We are hopeful that we're going to keep that in the community. We get a grant for it. I believe a certain amount of money is based on the volume that we provide, and a good portion of that volume was due to the long-term care. So I'm very hopeful that we are going to continue that, but I don't have an answer at this point in time. I do think that it's a valuable service that we continue to provide. So I'm sorry we don't have an answer right now.
Thank you.
Yes,
Thank you, Colleen. Joyce Adams?
I have a loud enough voice, I don't need a microphone, but I'm
I just wondered if we knew the amount of revenue that LTC residents generated for our lab, X-ray, ER, and inpatient. Do we know that?
So we don't have the exact dollar figure because it's tough to carve out. Maybe Viola can answer this better, but we did look at it. We looked at the percentage of volume, at least on the inpatient side. What you guys saw with that 1 to 1.5 million, that is the impact of the closure of the long-term care, as it has to do with the costs that do go over there currently and the square footage allocation. What that does not take into account is if we take any of our hospital or long-term care staff and they move into a position on the hospital side that is being filled by a traveler, which is over doubled, right? And when we looked at the expenses not too long ago of 6 contract nurses, it was $900, if you annualize it, it was $950,000 for 6 for 1 year. When we have our own nurses, plus their benefits, it came out closer to $400 to $500. So we will have savings there. We will have, depending on the square footage utilization, what happens afterwards, if therapy needs a little bit more space, which, you know, they always want a little bit more space and need some more space, that will change the impact on the cost report because now that is reimbursable instead of idle. So we are confident that, yes, we will see a decline in revenues in some of these departments. We also feel confident that it will be that decline in revenue will be offset by some of these other savings that we are going to have that were not included in that analysis.
Okay.
Is that okay?
Yeah,
Okay.
and I just wanted to agree with several others. These meetings are 2 weeks, 2 months, 6 months too late.
Thanks, Joyce. Dwight Cummins?
of all, hey, I want to thank you guys. You put together quite a lot of figures. Didn't understand any of it, but it doesn't matter. But I have to agree with Don. I was mayor in Quinter for 12 years. Open meetings are open meetings. You cannot go into a meeting and discuss what you did. That has to be open. Now, if I was buying a piece of property, which the city did while I was there, we could go in and we could discuss those finances. But you can't just go in and discuss. And I hope this isn't a big legal battle coming up, but it could be. So, but anyway, you put a lot of time in this. And you know, we've taken 30-some patients from these doctors sitting over here. Overnight, they lost, those are patients, not all of them, but I would say most of them. And we've taken a lot of the income from the hospital.
She just mentioned that the ones that were discharged locally will be able to continue if they choose to use the transport van, and we will use that service to continue to bring them back so they can continue to see their providers. Wakini as well. And yeah, no, it's not significant, but we need to.
Yeah, that's fine. I'm done. I was just in the open meeting part, and our former mayor sitting beside me, he agrees. You can't do that.
Well, and all I can tell you is what our attorney has discussed with us, and
I'm just going by the state laws.
Yeah, and I'm going by our attorney that interpreted the state laws.
The Attorney General of the United States. I'll read the state laws, and that's what it says, and that's the way it is. Thank you very much.
Thank you, Dwight. Then Donita Jean Oaks. The next one is, I'm having trouble reading this, we have to excuse me. Is that Chuck or Charles Kurt? Is that correct? Okay, thank you. Linda Rush.
I was just curious about other communities around Wakini, Oakley, Oxy, Nest City, Ransom. They all have long-term cares. What are they doing differently? What's happened different there with their hospitals? We're sending residents to those places. Are they going to be having to leave there soon too? Just curious.
So, depending on who you, what's that? Oh, thank you. Depending on who you ask about Wakini, and we have asked a lot of people that should be in the know, and some will say, well, the hospital owns it, and some will say it does not own it. So what I will tell you is that Logan County, for example, identified this issue years ago when they sold it. In fact, I was talking a long while back to their CEO in Oakley when they were doing their presentations for their new hospital. I went to their public forum, and I talked to her afterwards, and she said that if they had not been able to sell that long-term care, which they did not have the licensure issues, because I double-checked. If they had not been able to sell it, they would not be at a place where they would be able to get a USDA loan. As far as the other facilities, you can ask the same question about us. Why were we able to run it for all these years and now we can't? Every organization has different volumes of patients. Every organization has different revenues and service lines. Additionally, every organization has a different level of awareness around this cost report impact. And so I would question, one, are they able to absorb it better than we are because they have greater volumes, they are in a, like Colby, a town of, what is it, a little less than 10,000? Or they could even be in a town of 3,000 and they can absorb it better than us. We're in a town of 1,000, a county of 2,900. So we are not able to absorb it maybe the way that we were prior. And people say, well, why could we absorb it then and we can't now. Well, my answer is twofold. One, COVID. We've seen all the expenses, what it's done. You've heard from Chad Austin. My second one was, if we were able to absorb it, why were we in this place in 2016? So I don't know if that answers your question. Your second question was, what happens to these residents if those hospitals close? They're not going to divulge their hospital financials to us when we are sending out these referrals. We have been transparent when we have talked to families in the one-on-one meetings about this critical access piece, and a lot of them have asked, well, this nursing home that you're looking at for my loved one, is it attached to a critical access hospital? And we have had to say, yes, we know, or no, we don't know. So we don't have all of that information, but I think a lot of people are concerned about that. But look at long-term care in general. Critical Access Hospital Association aside. I mentioned South Dakota. Those 7 nursing homes that closed in South Dakota, they were not all associated with critical access hospitals. They are facing the same financial challenges in a different way, the same staffing crisis, the same supply chain issues that hospitals are facing.
And I'll add a little bit to that. I know Gene has checked too, and I did some checking myself. I called the director of nursing and long-term care in Waukene, and she can't tell me what kind of license they actually have. I talked to a board member that I know over there. He couldn't tell me the license. Is it a skilled nursing facility? I don't know. But he said they're losing at approximately $300,000 to $500,000 a year. That could be before the cost report. I don't know. I didn't ask that question. But they're also in the process of talking about raising rates as well. So that's all I know about that scenario. Thank you for that. Peg Davis?
Yeah, so we had a whole time frame on Monday of the rollout, and I'm sorry, I didn't catch the name. Okay, so we had a time frame on the rollout. We were trying to communicate with, staff members so that they didn't hear from residents. We were trying to make sure that we got our residents in immediately afterwards so they didn't hear from our staff. We pulled in our residents that it was about, I don't remember, 1:30 or 2:30 on Monday. Remember the vote took place around, I don't remember that either, I think around 11:30. So we moved as fast as we could. We pulled in the residents that had the ability to comprehend this conversation. And so we brought them in. I don't know, there were maybe about 10 of them. And we had sent letters to families.